Hello, and thank you for inviting me to speak at your conference. I really like the name TEAM for Trauma, Emergency, and Acute Medicine. I often say, we're all on Team Patient. My name's Ken Milne, and my presentation is called Is Evidence-Based Medicine, EBM, an Illusion? So let's start the presentation with a question. When I say, what is evidence-based medicine, what's the first thing you think of? Come on, think about it. Most people respond to this question saying, evidence-based medicine, it's about the evidence, the literature, clinical trials, observational studies, systematic reviews, meta-analysis. In other words, the evidence. And while that is true, I hope, after this talk, you'll realize that EBM is much more than just about the evidence. I find it generally a good idea before having a discussion to define terms. This can decrease misunderstandings. If we all agree on how we're using terms, we can have a better conversation. Focus more on the issue and less on the word we're using. Because I'm more interested in what we're talking about and less interested in the labels we use. So, let's get a definition for evidence-based medicine. This is the one put forth by Dr. David Sackett from McMaster University in Canada almost 30 years ago. He defined EBM as the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of individual patients. I really like this definition. The only little tweak I would have made is that I would have added the word shared in front of decisions. Now, each of these words is very important. We need to try to be conscientious about our decisions, be explicit about what we're doing, use our good clinical judgment, and look for the best evidence, not just the evidence that confirms our bias or what we already thought was true. Encourage shared decision between clinician and patient. And we need to care for individual patients, find about their values and preferences. This is because we take care of individual patients, not a population from a research study or a cohort. And extrapolating population data from research studies and applying it to individual patient care is a challenge of evidence-based medicine. But who said the practice of medicine was going to be easy? So that's the definition of EBM. What's it actually look like? Well, it can be described in a Venn diagram that represents the definition of evidence-based medicine. And there are three pillars or three circles. The blue circle is the literature, the relevant scientific information. It should inform our care. It should guide our care, but not necessarily dictate our care. As I said at the beginning of this talk, many people make the mistake of thinking EBM, it's just about the scientific information, the literature, which is not true. We need to know about the relevant scientific information and how to critically appraise the evidence and apply it. And that gets us to the green circle, the second pillar. That's your judgment. As a clinician, you need to use your good clinical judgment and apply the literature. Clinical judgment is very important. And sometimes you'll have lots of clinical experience seeing lots of cases. And other times, you'll have very limited clinical experience. And the red circle, the third pillar, this is very important. We need to ask patients, hey, what do you value and prefer? Don't just assume, ask the patient explicitly and respect their autonomy and agency. While we may be experts on the evidence and have expertise as clinicians, patients have their own expertise of their own life experience. They're an expert in what they want, and this needs to be considered. So these are the three components that make up EBM: the literature, our judgment, and patients' values and preferences. And there is a hierarchy to the evidence we use, and as the definition of EBM suggests, we need to look for the best evidence. And so this hierarchy of evidence is typically described as a pyramid. I like to use this stack of rocks. And you can see these rocks, they're not perfect. They have flaws, just like different forms of evidence have limitations. The lowest form of evidence is considered expert opinion. In the middle is randomized control trials, and the top of the hierarchy is considered systematic reviews. Now there is one better, and that is a double-blind, randomized control crossover trial with an N of 1. And this is because we want to know if the intervention will work in this patient we're caring for, not necessarily in a population or a cohort. However, you need to look at each individual study and critically appraise it for its validity. So let's dig into that a little bit more by looking at the top two levels of evidence in this hierarchy. The second highest part of that pyramid is critical appraisals of individual topics. These are often published as clinical practice policies or clinical practice guidelines. Unfortunately, guidelines are often interpreted as Godlines. Thou shalt do this, thou shalt not do that. If you actually go back to the primary literature and look at the level of evidence using something like the grade criteria, you'll find much of the evidence in guidelines is low level. In other words, we're often standing on pillars of salt and sand, and the foundation of our positions is very weak. An example would be the American Heart Association, or AHA, guidelines. Fanaroff looked at the last 10 years of AHA guidelines and found about 3,000 recommendations in the guidelines, and of those, less than 10%, so 9%, were considered level A or high-level evidence. The vast majority, 91%, were not high level. They were level B or level C levels of evidence. And if we go to the top of the evidence hierarchy pyramid, we find systematic reviews and meta-analyses. However, we need to watch out for something called GIGO. GIGO stands for garbage in, garbage out. It means if you're using crappy little studies and mash them all up into a meat grinder and spit out a point estimate down to the 5th decimal place that gives some impressive p-value, this is an illusion of certainty, when certainty certainly does not exist. I describe this with an apple pie analogy. I grew up on a farm, and it was an apple farm. My mom made the best apple pies. This is because she used great ingredients, like the wonderful apples found on our farm, and then cinnamon and sugar, and baked these apple pies with that extra special ingredient, love. Now, if you take all those wonderful apple pie ingredients and add a cow pie. Now, if you're not from a farm, a cow pie is something that comes out of the back of the cow, and it lands on the ground, plop, and it's about the size of a pie. If you add a cow pie to the apple pie, it doesn't make that apple pie taste any better. All you get is a poop emoji. If there is a great randomized control trial addressing a question and a poor systematic review full of observational studies, I would likely have more confidence in the high-quality randomized control trial, which is only mid-level on that pyramid, rather than the low-quality systematic review that is artificially placed at the top of the pyramid. And what are we trying to find out when we're looking for the best evidence? Well, we're searching for the, quote, truth. And when I use the term truth, I'm talking about the best point estimate of an observed effect size with a confidence interval around that point estimate. However, that's all it is. It's just an estimate with a confidence interval. And so my positions are tentative and subject to change when provided with sufficient evidence and logical arguments. And we'll all have different levels of evidence to accept a claim. A famous scientist, Carl Sagan, said, "Extraordinary claims require extraordinary evidence." And I really like this quote from Pascal. He said, quote, "There's no such thing as the truth. We can only deliver the best available evidence and calculate a probability." So in other words, certainty is often an illusion in science. And this gets back to, is evidence-based medicine an illusion? Well, we'd need to define that term as well. The Cambridge Dictionary says an illusion is an idea or belief that is not true or something that is not what it seems to be. Another definition by Merriam-Webster is that an illusion is something that deceives or misleads intellectually. So my answer is evidence-based medicine an illusion? No. I think it's just rather been misrepresented, contains some limitation, and has been misused as a tool. So here's what I mean by misrepresentation of EBM. I started this lecture by asking you if you think EBM or what you think EBM is about. And I think many of you may have been thinking it's about the literature. Hopefully I've shown you that it is only one of 3 pillars of evidence-based medicine. There's also your good clinical judgment and the patient's values and preferences. Just because we don't have high level of evidence like a systematic review or meta-analysis or a good randomized control trial does not mean we are paralyzed into inaction. We make decisions every day in medicine without having good evidence. Don't believe me? Wait until you see this next slide. This is an umbrella review that was published 2 years ago. It's a meta-analysis of systematic reviews and meta-analyses. In this study, Parrish et al., published in EBM, asked an important question. How much high-level evidence do we have to support what we do in the practice of emergency medicine? They searched the world's literature and identified over 400 meta-analyses with greater than 3,000 outcomes. About 80% of the data was from RCTs. And they found, you ready for this scary number? I hope you're sitting down. 2.8% had high-level evidence of an important effect size. Now, this does not mean what we do does not work, could not work, or does not matter. We've got to be careful not to overinterpret this number and this literature. What this means is we just don't have high-quality evidence of what we do does have a meaningful patient-oriented outcome. Less than 3%. That's a really humbling number. And that's why I say there are very few thou shalts in medicine. You can find out more about this study by checking out the SGEM episode number 361, where we interviewed the lead author. Now, some people try to knock evidence-based medicine down by using a fallacious argument, a straw man logical fallacy. A straw man is something that looks like a man, but it's made out of straw, so it's very fragile and easy to knock down. It's when somebody misrepresents your argument to make it easier to attack by exaggerating, misrepresenting, or completely fabricating someone's argument. It's much easier to present your own position as being reasonable. But this kind of dishonesty serves to undermine honest, rational debate. An example of this would be if someone claimed that EBM was just about the evidence, which again is not true. You need to use your good clinical judgment and consider the patient's values and preferences. Therefore, my position is EBM, it's not an illusion. It's just being misrepresented with a straw man argument that it's not only just about the literature. You need to consider the 2 other pillars. Now, there are a number of arguments against evidence-based medicine which are not fallacious arguments. I'm just going to talk about one of the limitations to EBM, and that is harm. It would be unethical to conduct an RCT on an intervention without equipoise. It would be harmful to allocate someone to a placebo or a control group when you knew that the intervention actually worked. The extreme example people often give is the parachute analogy. They say correctly it would be unethical to do an RCT on parachutes versus a sham control like a backpack. Smith and Pell, 20 years ago in the BMJ, published a systematic review on the topic. It was called Parachute Use to Prevent Death and Major Trauma Related to Gravitational Challenges, Systematic Review of Randomized Control Trials. They started by saying that parachutes have been used for years to prevent orthopedic head and soft tissue injuries after gravitational challenges, like jumping out of an airplane. Observational data showed that the failure of the parachute led to some morbidity and mortality. And there are studies, observational studies, of free fall that do not show 100% mortality, so some case reports. So they searched the world's literature, and they couldn't find an RCT to answer the question about the efficacy of parachutes. So they proposed taking EBM advocates like myself up in an airplane and randomly allocating us to either a parachute or the backpack as the sham, and then have us jump out of the airplane. And to make it more rigorous, those who survived would be crossed over into the other group and then jump out of the airplane again. That way, they would have definitive proof about the efficacy of parachutes. Now, they were clearly saying this with their tongue firmly in their cheek and understood the gravity of the situation. I mean, anyone who has fallen from a short height of a few meters knows the risks. Falling from an airplane 9 kilometers up in the sky, traveling at 800 kilometers per hour, is very dangerous. However, Hayes et al. In 2018 pointed out that most medical practices are not parachutes and you can do randomized control trials. And just for your information, somebody did conduct and publish an RCT on parachutes. They were able to get 23 participants to agree to be randomized to a parachute or allocated to a backpack. The primary outcome was a composite of death or major trauma, and they found that parachutes did not reduce the risk of death or major injury. It was 0% in both groups with a p-value of greater than 0.9. So this is an example why you can't just read the abstract. You need to be skeptical and critically appraise the study and look at the methodology. And when you looked at it, participants in the parachute trial, they weren't jumping out of an airplane 9 kilometers in the sky going 800 kilometers an hour, but rather they jumped out of an airplane that was parked on the ground and not moving. The height was 0.6 meters or about 2 feet, and it was traveling at 0 kilometers an hour. Now, what about some alternatives to evidence-based medicine? This is a fun article from 1999 that described a number of alternatives. I'm just going to mention 3 of them. The first one is eminence-based medicine. The more senior colleague, the eminent physician within your group, the white hair, no hair, balding patch, often called the halo effect. And these individuals that practice eminence-based medicine place less importance on anything as mundane as evidence. They think that experience is worth any amount of evidence. These colleagues have a touching faith in clinical experience, which has been defined as, quote, making the same mistake with increasing confidence over an impressive number of years. Eminence-based medicine. Another potential alternative to evidence-based medicine is eloquence-based medicine. There are these amazing people out there. You see them doing TED Talks, like Dr. Jennifer Gunter. She's a well-known gynecologist and a fantastic science communicator. She possesses verbal eloquence to deliver a message. However, we need to be careful not to believe people just because they're gifted speakers like Dr. Gunter. We should accept their positions because of the evidence in their logical arguments. We all know super smart people who can't communicate well, and also people that aren't so smart and can communicate well. Well, Dr. Gunter does both well. She is a phenomenal scientific communicator, and she knows the evidence and brings it. So just a caution, be careful about practicing medicine just based on somebody who's a good speaker alone. That is not a substitute for evidence. And a third and final example of an alternative to evidence-based medicine is confidence-based medicine. Yes, confidence-based medicine is where you practice medicine with an incredible amount of confidence, whether you're right or wrong. And this type of practice is typically restricted to surgeons. So back to the question, is evidence-based medicine an illusion? Well, Every, Palmer, and Howick thought it was failing back in 2014 when they wrote how evidence-based medicine is failing due to biased trials and selective publications. John Ioannidis came along a couple of years later and said he thought evidence-based medicine had been hijacked. Howitz and colleagues, a few years after their original article, modified their position for evidence-based medicine failing to the past tense, concluding evidence-based medicine had failed now. And they wrote an article, Why Evidence-Based Medicine Failed in Patient Care and Medicine-Based Evidence Will Succeed. And finally, and where I got the title for this talk, was a BMJ article, which I encourage everyone to read from last year. And it is called The Illusion of Evidence-Based Medicine. These authors also published an excellent book with the same title, The Illusion of Evidence-Based Medicine. It is an excellent book, but I do disagree a bit with their message. My position is evidence-based medicine, it's been misunderstood, misinterpreted, misapplied, misused, and even abused. but I don't think it's an illusion. I think EBM, it's just a tool. And like any other tool, it can be used for great good and what it was intended, to provide individual patients with the best care based on the best evidence while applying our good clinical judgment and considering the patient's values and preferences. Or evidence-based medicine can be used for great evil, misused for some other agenda. It all comes back to those 3 pillars of evidence-based medicine: the evidence that guides our care, the use of our good clinical judgment, and respect for the patient's values and preferences. So, is evidence-based medicine an illusion? No. I think evidence-based medicine, it's the worst form of medical practice, except for all the others that have been tried. If someone can propose and demonstrate a better way to practice medicine, I will consider their evidence, and if the evidence is sufficiently good enough, I will accept the claim and change my position as a healthy skeptic. Thank you very much.